computational psychologist in Odessa Medical Center and also in Ariel University. As part of my duty as a therapist of child and adolescent clinic in Odessa Medical Center, I met patients with a few months after they released from hospital, and I found they suffered from severe traumatic symptoms. Therefore, I decided to investigate the field of medical trauma among children and to look after the risk factors of this phenomena. And I'm going to tell you today of one of my studies in this area. So, disease and injury followed by admission to a pediatric surgical ward introduce children and their families to a medical environment in which they may experience fear, uncertainty, helplessness, and loss of control, and also painful surgical intervention and even life-threatening situations. We know that a child hospitalization may comprise a traumatic event for the parents, and we know that the rate of PTSD due to child hospitalization among parents is higher than that among children. Although most children recover spontaneously without experiencing chronic symptoms, a significant number of them develop post-traumatic symptoms affecting the course of their physical recovery and overall function. Rennick and Rashot reviewed 28 studies that checked children that were hospitalized in intensive care units and found that 16 to 28% of them had reported a decline in their quality of life and their emotion, and also emotional difficulties following this hospitalization. And Kazak found in her study that 5 to 10% of those children that had cancer meet the criteria of post-traumatic stress disorder diagnosis, and 17 to 21% of them had post-traumatic stress symptoms. Partial PTSD, not all the diagnosis, but just part of it. So let's talk about this new determination. The NCTSN define this phenomena, pediatric medical traumatic stress, PMTS. This definition includes a broad range of physiological and psychological and physiological reaction of children and their families to pain, injury, severe illness, medical intervention, and invasive medical treatment. Why do we need a new definition? We know that part of the children don't develop the full-blown PTSD, just part of it. They got just part of the symptoms, but they are still suffering, and we have to help them. Otherwise, their problem will get bigger. So we need a new definition, and this is the definition that the NCTSN discovered or found in the 2003. We know also that the consequences of PMTS in children is included persistent emotional distress, persistent impairment in functioning, and also low adherence to medical follow-up. It's something that's very bothering us. We also know that there is a lack of awareness among the professional staff. In a study of that's checked 2,087 pediatricians, they found that PMTS awareness is very low. Only 7% of those pediatricians believed that children could develop psychological symptoms due to hospitalization, and only 11% of them were familiar with methods to assess such symptoms. Also, it was found that due to inefficient awareness, the identification of the emotional distress often occurs only once the difficulties had become more severe. And we know that late identification hinders the possibility of early intervention, which has been proven to be effective in children and also in adults. So this low PMTS awareness can be explained by the fact that the treatment during the acute hospitalization is focused, of course, on the physical status of the child, and not enough attention is paid to the psychological consequences of the situation, of the mental situation, and the psychological consequences. Okay, so here are the results of the previous studies that we have done. The findings of the study showed that 3 to 5 months after hospitalization, a significant number of children aged 1 to 13 suffered from chronic psychological difficulties. The meaning of this data is that these children suffered from persistent emotional distress, persistent impairment in functioning, and lower compliance or adherence with medical follow-up. According to the regression analysis among children aged 1 to 6 years old, the risk factor that was most predicting PMTS were parental stress symptoms, length of hospitalization, and high number of invasive procedures. So let's talk about the parents. Parents of children with chronic illness faced various consequences of the illness, and simultaneously most face intensive care for their child following the illness. Parents deal with the increased emotional distress after the detection of the disease, well as with feelings of uncertainty and perhaps even the fear of their child life. As a result, these parents experience high level of stress and are at increased risk of developing anxious disorder, depression, PTSD, and also adjustment disorders. There are many factors that can affect parents' ability to adapt to the new situation after their child illness, or instead the risk of developing anxiety or stress disorders. We know that the parents' beliefs is very important. The correlation between disease perception and the patient core beliefs or on psychological symptoms, there is a positive correlation. We know that core beliefs defined as a general set of beliefs and assumptions about the world, about the self, and about the relationships with others, mostly with the child when we're talking about the parents. And we know that after traumatic event, these core beliefs are challenged and become unstable and uncontrollable. And there is a possibility of re-examination of core beliefs and development of post-traumatic growth. This is the positive path when the parents are getting better. Perception of the disease as understandable and managed and finding meanings in coping were found to be positive. Maladaptive perception that included helplessness, a sense of threat, and sense of vulnerability were found to be to have a negative effect. The first objective of this study was to examine the correlation between parental beliefs and the child distress. The second objective of this study was to increase awareness regarding the influence of parents on the child undergoing surgery, and thus reduce the rate of distress in this population. Let's talk about the sample. Based on convenience and continuance sampling, parents of 149 children aged 1 to 6 who were admitted to a pediatric surgical ward at Hadassah Medical Center in Jerusalem, Israel, participated in this study. The mean age was of the children was 2.8 months, almost 60% of them was males, and the rest was females. 68% of those children had undergone elective surgery, such as hernia, cardiac surgery, and so forth. And the rest underwent emergency surgery, such as appendicitis, orthopedic surgery, and so forth. The mean hospitalization length was 4.5 days, with a duration of 90 days. That was the most, the higher duration of one of the child. Okay, this slide is about the method. The study included 2 stages. In the initial stage, parents filled out a short demographic questionnaire and the family illness beliefs inventory, the FIBI. In the second stage, the parents completed the UCLA and the YCPC questionnaire that's assessing the medical trauma and the PMTS, and also the PDS questionnaire that assessed the parents' level of distress. With the help of the researcher during the face-to-face interview, we did it by clinicians. So this is the findings, main findings. According to a mediation hypothesis, parental distress is the mediating factor in a relationship between parental beliefs and post-traumatic symptoms. As can be seen from this slide, from this figure, the path between the perception that the child will be in a great pain and the parental distress is found to be positive and significant. The rest of the beliefs were not found to clearly predict the level of parental distress. In addition, the pathways from the level of parental distress to PTSD score were also found to be positive and significant. Accordingly, the mediation path between the perception that my child will be in great pain to score of UCLA questionnaire was found to be positive and significant. This result support that the mediation hypothesis was partially supported. We found that the more the parents believe that their child will be in pain, the greater their parental distress, and the greater the parental distress, the higher the post-traumatic symptoms. We are in the process of developing a screening tool for the identification of children that are in high risk for PMTS following hospitalization in surgical ward. So let's talk about the main conclusion. First, there is a potential link between certain parental perception and post-traumatic symptoms among children after surgery. Second, parental distress has a positive and a significant correlation to post-traumatic symptoms among children after surgery. Third, catastrophic thinking of the parents regarding the child pain is correlated with worsening of the child distress. We are now in the process of developing a screening tool for the identification of children at high risk for PMTS, as I said before, following hospitalization in surgical ward. Introduction of this tool to the routine work of the ward will increase awareness and enhance the preventive intervention. Okay, thank you very much.